Thank you. Well, I did think, as we were getting to the end of the day, that I would take you through a blow-by-blow account of each policy, but I thought you would probably kill me. And so what I thought would be better to do would be to go through some salient points and not everything. So the chemotherapy-induced guidelines for diarrhea are currently under review and will be about to be published. We have taken it from a sort of a 2-page document up to a 12-page document, but it covers quite a lot of aspects that we have already talked about. And I think 3 issues to take away from what we've heard today is patients who are receiving chemotherapy like capecitabine and diarrhea. They can be DPD deficient, and therefore post cycle 1 it's always being observant that if they do develop diarrhea, it's monitoring them very quickly. Have they got mucositis? Because they can very quickly go into neutropenic sepsis. So, and I think the 2 case histories that we've had today have highlighted that. And actually we need to be aware when we're educating patients. If diarrhea happens very quickly after receiving or starting capecitabine or a 5-FU infusion, that the patient's highly likely to be DPD deficient. The second part with chemotherapy-induced guidelines will be those patients who are on some of the new targeted therapies like TKIs. They're the oral drugs. And for about 28% of those patients, they're going to develop grade 1, grade 2 diarrhea that they can actually manage with loperamide and diet. But nurses who are looking after those patients will need to read up much more about diarrhea, how to control it, the use of loperamide, the use of diet, and actually can go a long way to supporting patients and keeping them on those treatments for as long as possible. And then the third group is the new immunotherapies that are coming out, which Simon has referred to, and it's the colitis. And I know within the network there is going to be a policy developed around colitis, immunotherapy-induced colitis, but we have included a section in it on the new policy. So it's just being aware, if going away from today, it's those 3 particular groups of patients, and what can we do to manage them, not just from a medicinal point of view, but it's also remembering all of our non-medical pharmaceutical treatments, so things like diet and coping skills for patients. What we have taken out of the guidelines will be the effects of radiotherapy. In the old guidelines, it did actually was radiotherapy and chemotherapy induced diarrhea, but because the radiotherapy departments are currently reviewing their guidelines and their treatment options also do vary, they're actually going to be writing their own guidelines. The chemotherapy-induced nausea and vomiting protocol has just been recently reviewed and is available on the website, the TVSCN website. I think there's just a few things just to point out from that. Is metoclopramide. There was an MHRA guidance released, and it said, so for those of you, and I'm not going to name names, who've worked in chemotherapy a long time, we will remember the days when we gave high dose metoclopramide, and that was before we had our 5-HT3 antagonists. And I think we used to see extrapyramidal side effects a lot. Does everybody know what they are? I need a more robust yes. I say that only because the MHRA guidance recently said about not going more than 10 milligrams TDS. And actually in our protocols and within the network, we do say 10 to 20 milligrams QDS. And we've sort of gone against that because given that we're a group of experts who have years and years, now I'm talking 30 years experience of using these drugs, we don't see the extrapyramidal side effects so much. But on saying that, we've had 2 cases in the last year into DTU, and it's just reminding our junior colleagues, nurses, doctors, pharmacists, haven't seen it. They don't know what it is, and it is actually remembering to remind staff and educate them. And the actual antidote for it is procyclidine IV, IM I should say, and it works very effectively. So always be aware if your patient comes in and they've got neck stiffness, their tongue, it's not that it's big, but it just feels big, and they're having difficulty speaking, they can be having this side effect, and it's time to swap them for metoclopramide. Also, an MRHA guidance came out recently, and it's about the use of domperidone, and it recommends that no more than 10 milligrams TDS is given to patients, in particular those over the age of 60, because of the risk of them developing ventricular arrhythmias or even death. And recently, with the new guidelines, we've simplified the dexamethasone, which is great. We've gone back to 8 milligrams BD whilst on chemotherapy and taper it off to over 2 to 3 days. And we've got rid of the 6 milligrams unless they're on a prepitant. It's also remembering, and I'm not sure for people who come outside of the network, but if patients don't have any degree of nausea and vomiting, post-cycle 1 chemotherapy, especially the highly emetogenic ones, such as FEC or our cisplatin regimens of about 40 milligrams, that we can actually introduce a prepitant or fosaprant. And that's really all I'm going to say. The guidelines are very comprehensive, and it's actually worth getting them out and reading them. Extravasation were reviewed, and just to say that for vesicant drugs that extravasate, that we've taken out the dexamethasone. There was a time when we used to inject dexamethasone 4 to 8 milligrams in the subcut around the site of extravasation. That's been removed. There was no evidence for it. Likewise, the application of hydrocortisone cream has also been removed. There is no evidence for it, but there may be times some people, for a placebo effect, may continue to use it. There is an antidote available for anthracycline extravasations called Savine. It was several years ago, when it first came out, the network decided not to use it for a variety of reasons, and it's currently under review, so we will have a look at that. The company, a new company has recently taken over the drug, and they're starting to push it again. Scalp cooling, it's not policy related, and I've left my magazine, but I picked up the BJN, the last edition, and there was a nice article in it on scalp cooling. Didn't say huge amounts that for those of us that are experienced chemotherapy nurses who've been using scalp cooling wouldn't know about, but I think the one thing that I picked out of it, and maybe I'm old school, but I worked in the days when we tried a bit of scalp cooling, but patients weren't having anthracyclines, and there was always this risk of them developing scalp metastases. And that risk, to the best of my knowledge, has stayed throughout, even if it's become a theoretical risk, that if we do scalp cooling for certain groups of patients, there's a risk they can develop scalp metastases. And what this article by Annie Young says is that there was no evidence to that risk. So I think it's just quite nice that this theoretical risk we've had, actually there is no evidence. And in particular, since we've introduced 15 to 20 years ago, the use of anthracyclines in treating breast cancer. And finally, I'm not going to go into all the ins and outs, but this was just an incident that happened, and it's really to highlight the importance that all of us have a role in ensuring we do pregnancy prevention discussions with our patients, not just from a nursing point of view, but right across the board. This will be pharmacists and our medical team. So we had a 42-year-old lady, I think all of this has been anonymised, who was receiving adjuvant herceptin for breast cancer. She had got to cycle 15 and developed progressive disease. But because her disease was rapidly progressing, she was immediately swapped to capecitabine. Post 2 cycles of capecitabine, she then had further symptoms of progressive disease and had a CT scan. At her pre-scan discussion, she confirmed that she had been amenorrheic since her chemo. She had finished chemo nearly 12 months earlier, and she was 100% convinced that she couldn't be pregnant. But then her CT scan went on to show that she was 12 weeks pregnant. In this instance, no discussion around pregnancy prevention nor pregnancy tests had been completed pre-capecitabine. And putting all those issues aside, it then raised the issue of patients who are on long-term treatments, on long-term herceptin, and also when should we do pregnancy tests. So we discussed it recently at the Chemotherapy Network meeting, and it is saying that all patients following the clinical trials guidelines should have a pregnancy test prior to starting any new SACT. But throughout treatment, regardless of how long it goes on for, is we need to keep bringing that into discussion. We can't ever stop forgetting that we need to have these pregnancy prevention discussions with patients, and acted as a reminder. And that's it. I am stopping there. It's 4:30, and I figured, I think the last update I had was Wales maybe 1-up. I don't know, on the football. 2-1 England. Oh, 2-1 England.
Thanks, Liz. There are a couple of things before you all go. Things I just want to ask about. With the nausea and vomiting guidelines and the bit of discussion that we had, I think, when Professor Gralla came at the end of last year, around whether we have dose reduction or whether we just stop. Nicola, do you want to say anything about the outcome of that discussion? That with the dexamethasone, we're still going to do a reducing dose?
So the anti-emetics on the policy are actually in line with ASCO. And when there was that long reducing dose, that was never evidence-based, never in line with ASCO. It was put on ARIA when ARIA was initiated, and for a long time the anti-emetic guidance didn't match ARIA. So I updated the guidance to match ARIA, rightly or wrongly, because at the time nobody wanted to change the reducing dose of dexamethasone. So now we're back to where we always should have been, of it being evidence-based without having that tailing dose. So obviously there are some patients that if you stop dexamethasone when they've been on 8 milligrams BD or even 4 milligrams daily, and you just stop it, they can have side effects of suddenly stopping dexamethasone. They can have the mood swings, which is the main thing, and go into usually a real low. And so there may be certain patients that you want to reduce it slowly if they do have those symptoms, but on the whole we wanted to make it as simple as possible.
So thank you very much all for coming.